Welcome, Gina.
Okay. Well, thank you very much for inviting me to talk about, give two talks, and today's talk is about staging of colon cancer in the context of some of the data that's coming out of the Foxtrot trial, but also about how we improve staging of colon cancers. I think generally that there is a need to improve things for colon cancers, and quite how we get there is a matter of discussion. But certainly what we've observed in the UK is that the survival outcomes for colon cancer is now worse than the survival for rectal cancer, which is quite surprising. So the main thing about colon cancer and just staging as a whole is what is the purpose of staging and what is the purpose of preoperative staging? And to my mind, it isn't about replicating TNM if TNM is not prognostically accurate in the way that we look at them on images. And so we have a bit of an obsession with lymph nodes, but the problem is on imaging, lymph nodes are often a good thing. We see very enlarged and reactive lymph nodes, which are actually a feature of a good prognosis tumor. So we need to understand what are the biological features that we're seeing on imaging that will help us decide who is at high risk, who needs a very careful operation, and who indeed needs adjuvant therapy. In rectal cancer, you can see that there's a whole level of stratification, which I'm going to talk about tomorrow, which is very different to what we do for colon cancer, which to date has not really been very reliant on imaging at all. And people can argue that that's actually fine. There is something that we can do for imaging, and the question is, what do we do to make use of it? So briefly, I think traditionally you will see most of your colon reports are about TNM, and they will be talking about whether something is T3 or not, and then they will be scratching their heads about lymph nodes. And I think the previous speaker saying that you won't get two radiologists to agree on the stage is absolutely correct, especially if you're using the TNM stage. And that's what we have discovered. So in fact, does it really matter? One radiologist says this is T2, and another radiologist says it's early T3. Yes, they're not agreeing, but actually what they are both agreeing is that this is a good prognosis tumor. And I think actually if you look at things in that way, is the radiologist able to identify the bad actors, the bad tumors, and are they able to identify the good ones that you can not be too concerned about and definitely don't need to overtreat? Then you get some way into being more meaningful with your stratification, and I will illustrate that. So here's a very sort of good prognosis. Perhaps everyone in the room can see that there's a little bit of infiltration, but it's only a couple of millimeters into the pericolonic fat. This patient after surgery is unlikely to recur, and we see that from their outcome data. On the other hand, if you see tumor that's breached the serosa on CT, by the time it's breached the serosa and visibly done so on CT, that's a poor prognostic feature because we won't see the microscopic T4, but we certainly will see gross evidence of T4 perforation. So in that situation, what we're looking for is the ability to see the peritoneum and the ability to notice if the tumor is infiltrating on the mesenteric side or if indeed it is infiltrating on the peritonealized surface. And by making that very simple distinction, you are able to know whether this patient has a risk of developing peritoneal recurrence or indeed whether the focus of the disease spread is within and along the mesentery. So here we have an example of a tumor that has indeed infiltrated along the peritonealized surface. This patient is at risk of developing peritoneal and a mental recurrence in the future. Is it worth knowing about that before you operate? Arguably, we don't know. We don't have any data because such data has never really been acted upon in preoperative staging and preoperative treatment. So the point is that that is a risk factor, and can you mitigate that risk? And how do you mitigate that risk? Similarly, this patient has tumour growing into a vein. We know from the outcome data that this patient may well relapse from metastatic disease in the liver. Looking at it the other way, that the only patients we see with metastatic disease in the liver have been patients with vascular invasion, and most of those can be demonstrated on the CT preoperatively. So again, the question is asked, if you knew about this preoperatively, would you have done anything different? Would you have started their preoperative treatment sooner rather than later? And do we really believe that lymph nodes are the cause of recurrence and metastatic disease in patients with colon cancer when we see that EMVI, vascular invasion, is present in 30 to 40% of the patients that we scan? So that is the big question, is are we looking in the wrong direction for the causes of recurrence? And is it possible that EMVI is the cause of metastatic disease, and that the lymph nodes react to that and may react positively to that, and may be in fact a defense mechanism? So chasing after the lymph nodes may not be the best way of dealing and preventing metastatic disease, but rather looking at the vascular invasion may be a better approach. And it's something that wasn't really looked at in the Foxtrot trial. So here we've got examples of tumour growing into veins. And what we have shown is that previously, when we've looked at these scans, and I won't spend time looking at the flow chart, but essentially, when we stratified according to good versus poor, putting the early T3s into the good prognosis and the patients with an absence of EMVI into good prognosis, we saw this big separation in survival that was the same in histology as it was on stage, on CT staging, which was not just stage of TNM, it was good or poor T3s. So what that means is that you won't get agreement at each stage between radiologists, but what you will get agreement for is whether something is good or poor. And that is a much more useful way of asking a question to the radiologist. Don't ask them, is it T2 or T3? Ask them, is it a good T3 or a bad T3? And then you'll get a sensible answer. So the depth of invasion beyond the muscularis is a very good prognostic factor to measure, and it has good correlation with histology. And what we find is that tumours with less than 5 millimetres of spread have an 87% 3-year survival, and those with more than 5 millimetres of spread have a poor survival. What happened in the Foxtrot trial is we started with this and we published the first 150 patients in Lancet Oncology, showing that this was a useful strategy. But mainly, I think, because there was a big recruitment target, they changed the entry criteria to include all T3s. Personally, I don't think that was the best move, because what happened is you identify patients with good prognosis and you give them perioperative chemo, and probably they didn't need it. So what happens then is you dilute the impact of what could have been a useful treatment, and we now don't know for sure if it is truly beneficial for patients. The other thing that happened is that the surgery was not standardized in that trial, and we don't know how much CME was being performed. So when we look at the prognosis of these tumors, we also can identify those patients where the tumor has perforated the peritoneum. This is an example of it. And what that means is, although we're not going to find all the patients with T4 disease, when we see it, it's prognostically relevant. So these are the sorts of things that we can help with in terms of prognostication. So here's an example of a patient who's got tumour growing along the vessel. Yes, there's a lymph node, but what is driving the prognosis? Is it the lymph node, or is it the tumour growing along the vein? I would argue that our data suggests that it's not the lymph node, it's the tumour driving itself along the vein and onwards to form recurrences in distant places. And actually, this is the bystander. This is an effect of this process, the actual underlying biology. the vascular invasion. So the traditional mindset has been to do the colonoscopy, to do the CT, perhaps not really pay much attention to what the biology is being depicted as. And actually, this works for the majority of patients. However, probably not enough for the high-risk patients. So we find high-risk patients, we do need to think about better ways of improving their survival. So the high-risk group are those patients with MVI-positive disease, tumour deposits, T3 spread more than 5 millimetres, and potential CRM involvement. In colon cancers, we're talking about adjacent organs and adjacent structures, such as the abdominal wall, etc. So this is the thing, that despite high lymph node yield and clear margins, there is still a problem with recurrence and distant recurrence. And it is so that a high lymph node yield is a manifestation of patients having a good, healthy immune system. Then this may explain why having lots of lymph nodes in your specimen may not be quite as simple as having great surgery. It may simply be that the patient has produced a good immune response. So if that's the case, then the rest of this talk starts to make a bit more sense. Because when you start to look at these tumours differently, and if you look for a vascular invasion, you look for what's happening at the mesenteric border, their tumour growing into vessels, and when you see it, you document it, you start to find this other thing, which is not lymph nodes. So a lymph node forms a nice acute angle with a vessel. The tumour deposit growing along those vessels, those are the things that we should look out for. And when we see those, that's a poor prognostic. They have previously been misclassified as lymph nodes, but actually they are extranodal. Often you'll see on the pathology reports that this is a fully replaced lymph node. And the chances are that it's not a fully replaced lymph node. It is actually a tumour deposit. So we have examples of differences between lymph nodes and tumour deposits. These are the deposits, these are the lymph nodes. Very different in their architecture. They line up along and they expand the vessels. They produce this sort of comma-shaped or comet tail shape, whereas the lymph nodes are separate from the vessels and are usually sort of ovoid. And they can get to any size. So we know that there's no relationship between the size of the lymph node and whether it's malignant or not. So therefore, we shouldn't be using the size measurements to tell us that things are malignant. So this is how we did a study that was published in JAMA. And this is how bad using TNM is on CT. There is no difference in survival using this TNM staging system. However, when you stratify patients according to the tumour deposits in EMVI versus the absence of those, you see a striking difference in survival. So it is prognostically much more accurate. And here, this next curve tells us why trials which are not discriminatory for the T3 tumours, i.e. they treat all T3 tumours the same, will be negative, because these are patients who are T3A and T3B tumours showing exactly the same survival as the T1 and T2 tumours. So you should no more give preoperative treatment to a tumour confined to the bowel wall as a tumour that has less than 5 millimetres through the bowel wall, and that is irrespective of whether or not lymph nodes are involved. So here we have this situation where you've got a striking difference in tumour and outcomes that is not related to the P stage. It's related to the amount of spread beyond the colonic wall. So when we do multivariable analysis, we find the only things for local recurrence are the tumour deposits, which are these things creeping along the vessels, peritoneal infiltration on CT, and EMVI. So we're going to develop strategies for improving survival for these patients. These are the areas that we need to focus on. So I will through this in the interest of time. The sort of take-home message is that colon cancers and sigmoid cancers have been neglected in terms of staging. we can use CT to stratify these patients. And patients who are low risk need not be treated with a very intense preoperative strategy. But the high-risk tumours may well benefit, and we just don't know what that strategy should be, may well benefit from some sort of strategy, whether it's more careful CME dissection, more careful attention to the vessels and the vascular planes through CME, whether it's the use of preoperative treatment, we don't know. And that's something that we'll need to look into in the future, in future studies. But certainly what we do know is that a selective preoperative strategy will need to be used, because you cannot treat all T3 tumours the same. You're going to over-treat a whole bunch of patients. But we also know that those high-risk patients deserve better surveillance. They deserve careful CT imaging of their liver, because that will be the site of their metastasis and of their lung. So those patients, when we pick up their metastases, may yet still survive their disease, because early pickup of the liver met will result in a substantial cure for many of them. So thank you very much for listening. I hope I've kept to time. And I'm happy to answer any questions.
Thank you, Gina, for that excellent overview and a very refreshing look at staging of colon cancer through CT. The session is open for discussion. Any questions?
Yeah. Gina, just I want to know, it looks like as though the whole of this rectal components, whatever we talk about rectum for MRI, so the same thing is getting extrapolated here for the CT scan. Is this the EMBI, all those things, the T3, CED, how obviously you should be comfortable in making out all those things in a CT scan. How comfortable is it? We just want to know. That's all.
Yeah, I think it's not as easy. I have to say, it's not as easy in the colon to look at these things as it is on the rectum. But on the other hand, when you see an obvious case of it, the positive predictive value is very strong. Okay. So I think the thing to do is to not overcall these things, not to get too enthusiastic about it. If you see obvious tumour growing into a vein, then you should call it.
Okay.
And not get too hung up about the size of lymph nodes, unless you see them tracking along the vessel.
Right. See, the previous discussion was on large volume disease in the colon. So what is your take on a PET CT during those cases?
I think the problem with PET CT is it lacks the anatomic precision that you do need to stage these tumours and to stage the biologically bad tumours, bad behaving tumours. I think one of the things that the CT and indeed MR can do is you can separate out the innocuous lymph nodes. You can see that when an enlarged lymph node glows on PET, that very often that could be because it's a reactive node. And that's one of the pitfalls of relying too much on PET CT to stratify and stage patients. And we see that a lot, for example, in the retroperitoneal lymph nodes, and we've all seen cases where you say, oh my God, they've got metastatic disease, and 5 years later, that retroperitoneal node is still sitting there and nothing has happened to the patient. So I think relying on PET CT on its own is not going to be helpful, but its use in answering some queries may be helpful. And of course, in surveillance, it may well be a useful tool if you're doubtful about something being metastatic. You can see that it perhaps doesn't change on sequential imaging.
Yeah. So, do you recommend any specific type of CT scan? We usually order a triple phase. So, do you think any specific type is needed in order to delineate all these details?
Yeah. So, this is at the moment anecdotal, and we need to formally study this. But our study on it was the DRIVEN protocol, where we looked at about 300 or 400 CT colon studies. in amongst those were some CTC studies, so virtual colonoscopy. And those 80 patients who'd had a virtual colonoscopy CTC study, the accuracy for those, the prognostic accuracy, was way better than conventional CT. And we're not quite sure why that was. We think that it may be that because you're delineating the luminal aspect of the tumour better through the colonic distension, you can then focus a little bit more on what the true invasive border of the tumour is, because you haven't got this problem of the collapsed bowel. So maybe that's why CTC was more accurate, but we need to test that. So we're planning a 150 CTC versus 150 standard stage standard CT patients. But the actual CT technique, no, I mean, modern CT scanners or even older CT scanners are perfectly adequate. And a contrast is the only thing. It doesn't need to be triple phase.
Thank you.
Gina, I'm Dr. Chandra Mohan. Thank you very much for coming to this meeting, and also wonderfully you are doing a radiology workshop. Thanks to you. So I think what you are teaching and what you are popularizing is high-end radiology. And even regarding reading of MRI scan, we see a lot of interinstitutional discrepancies. If you go to many places other than highly specialized unit in India, you won't get this kind of expertise. And of course, thanks to your Mercury 1 and 2 trial, we know a lot of things about MRI of rectum. But in this case, in colonic, when you discuss about colonic CT scan, it is more intriguing. And how do you think that this can be disseminated across the globe to various radiologists? And are you aiming at doing some programs at large?
Yes, I think in a way it's growing awareness of the lack of importance of measuring the size of lymph nodes, which is quite a hard thing to undo when radiologists are taught from day one to measure the diameter of a lymph node, and they talk about things like pathologically enlarged lymph nodes as being a prognostic feature. So one is educational awareness, and actually having some multi-center studies like the Mercury project to get radiologists to prove that radiologists can do this, and if radiologist X in some small district hospital can do it, then everybody can if they put their mind to it, and if they're disciplined about the way in which they look at the scans. None of it's rocket science. There is much harder work in radiology, like interpreting chest X-rays. That's much harder than looking for vascular invasion and tumor deposits. But it's the discipline. It's having that structure when you're approaching a CT that it could be trained. It's not a difficult thing to train.
Yeah, of course, in this contest with the Indian Association of Surgical Oncology, we are inviting you to help us to have combined knowledge dissemination of attempts, as well as we can do some combined research activities as well. Thank you very much.
Very happy to do so. Yeah, thank you.
The session is also open to questions to Dr. Wesley, the previous speaker. Anybody else, any thoughts?
Wesley, I think you seem to disagree with radiologists in most of the things. So can you spell it out, what is the differences, and we can clarify with Gina Brown as well.
Right, I think I didn't have differences with Dr. Gina Brown, but I probably trust my surgeons more than the radiologists in town. Maybe my question to you, Dr. Brown, would be how steep is the learning curve for the radiologists to pick up all these minute things which do matter, especially when you're talking about neoadjuvant chemotherapy in colon cancer?
Yeah, I think, Anu is tomorrow going to be doing the workshop with them, and perhaps you can ask the radiologist before and after how they feel about it. But I think most radiologists feel a sense of relief when they realise that they shouldn't be asked about lymph nodes anymore because it's pointless. They should be asked about vascular invasion, and they should be asked about the degree of T3 spread. So if they can do those things, it's in two directions. One is people need to ask the radiologist the correct questions. So don't ask them about lymph nodes and don't ask them about T stage, but ask them how is this behaving? How much spread can you see into the mesentery? How much EMVI is there? Is the peritoneum clean of tumour? Or is the tumour on the other side? Is it on the mesenteric side? So these are quite simple questions, and most radiologists will feel a sense of relief from not being asked about the lymph nodes, particularly. But I think if they then spend a little bit of time just tracking the vein, looking along the vein, is there something along the course of the vessel that they should be concerned about? Is there something that's expanded that vessel more than you would expect to see? And that's when they can start to pick up the tumour deposits. It's not hard, actually. If anything, it's a lot easier. But it's just changing the way you look at those scans.
Let me ask you a very stupid question, Dr. Brown. How long does it take for a radiologist to read a simple CT abdomen, which is done for a colon cancer? How much time would you spend on a single CT?
Initially, I would scroll up and down in the axial plane, and if I see lots of nodules, it's a bit time-consuming, because then I have to flip the plane to see if it's actually along the course of a vessel or not. If I don't see anything in the mesentery and the tumour is not spread very far, then it's very straightforward. It's when you get this very messy colonic mesentery and you see lots of nodules, that's when you have to sort them out. But the good thing is once you've found a tumour deposit, once you've found EMVI, it doesn't matter if you find 3 or 4 more, you know that patient has a bad prognosis. So job is done, you can move on to the next case. So I think, that's how I encourage people to sort of be disciplined about this and to search to track the whole vessel all the way to its origin. So, the right colon vein should be tracked all the way up the mesentery, not just in the first sort of 3 or 4 centimetres. And I think that's been the key to CME success, is because they're not only removing all the lymph nodes, they're removing the draining vessels containing the tumour deposits in an intact package, which is why, possibly in that subset of patients, there is a benefit.
Right. So I'll leave it to the crowd.
Yes, I have one thing for you. So you've been always, we get to see only this capox and Folfox. Anything else you are in favor of? Don't laugh there, Sandil. I'm just asking seriously. You're laughing there. So, are you anything else?
Are you in favor of any targeted treatment or any
something like that?
molecular?
Because the way with some sort of thing you were speaking, these are 2 drugs available with these are the 2 combinations. Or you FOLFIRINOX, something like that, which you feel which might have some benefit on the circulating cells, so that you can reduce the thing for surgeons also.
Right. A situation where you think a major vascular resection or a major visceral resection is going to be necessary, probably intensifying chemotherapy might be of some use. People might use FOLFIRINOX. There are a few studies, but they're not large enough to say that that would be the standard of care. So standard of care still remains Capox or Folfox. The neoadjuvant setting, even in the adjuvant setting, the targeted therapies are out of question. So it doesn't come into the neoadjuvant picture. The only thing that we have for now, for sure, based on biomarkers, is the MSI. If the MSI is deficient, then probably you're justified in using immunotherapy and probably avoid the chemotherapy at the later stage. Other than that, we do not have data, not robust enough data to make that statement.
I think with that, we'll close the session. We've had some great insights on CT features. We've had insights on neoadjuvant chemotherapy. We've had some great videos on standardized treatment, surgery, and on advanced surgery for colon cancer. I think it's a combination of all of this which will help us improve outcomes. Thanks you once again. Thank you, Gina, for joining us and taking the time. And thank you to all the speakers.
Thank you.